Okay, and is my screen visible now?
Yeah, I think it's now. It's not opening yet.
Yeah.
Yeah, now it's visible. Yes.
Thank you so much. Thank you
Yeah.
so much for this patience. And I have been listening to this statement in various scientific forums by various neurosurgeons, various speakers that they will never send any Cavernoma for radiosurgery, period. And in the last 15 years, many a times I started giving counter arguments in favor of stereotactic radiosurgery, especially for the brainstem cavernous malformation sometimes. And then I had been listening to this statement again and again. My this talk is based on my experience on treating around 220 patients of cavernomas, out of which around 98 were gamma knife radiosurgery treated for the brainstem cavernomas, with no particular financial disclosures, but with my experience with the gamma knife radiosurgery. And these are a couple of my disclosures. I do operate some brainstem cavernomas, and I give radiosurgery to many brainstem cavernomas. My second disclosure is that I do not believe in this concept of an unbled cavernoma. All cavernomas, whenever they are diagnosed only when they have bled, because there is no radiological signature of an unbled cavernoma so far. It might be a symptomatic bleed, it might be an asymptomatic bleed, but if you are seeing it on an MRI, it's a bled cavernoma. Since the end of the 20th century, the cavernous malformations emerged as a distinct clinical entity, and now we accept that its natural history is complex, variable, unpredictable. So far in the literature, if you just go with the surgical arms, you will find only two options. Either you operate or you observe them, because we think that this is a benign entity. If symptomatic, operate on them. And stereotactic radiosurgery does not make it disappear, it's of no use. So forget about it as a treatment option. That's the usual notion that we get. And if some patient is really adamant over it to get the radiosurgery, they are told that it does not make them disappear from the scan, so it's mostly just a palliative, not a curative one, because we like the clean scans, and the patient also likes the clean scan. And they had to operate on some of these irradiated ones. It was not difficult to operate on them, but in their view, probably it changed the natural history of the disease. The results do not give you a robust protection during the latency period of 2 years, and probably only after the 2 years you get some good benefit. And a radiation therapy is a radiation therapy, howsoever precise, howsoever focused it might be, even if it is as focused as gamma knife radiosurgery. And they do not make a difference whether you are firing with an AK-47 or you are using a sniper bullet. That's the main problem in this understanding. If you look at the natural history, a common misconception is to consider all cavernomas a benign entity, which is not as dynamic as an AVM and never as ferocious as an aneurysm. But a hemispheric cavernoma cannot be compared to a brainstem or a thalamic cavernoma in that way. Natural history studies suggest that transition from the independent to the dependent status usually occurs after the second symptomatic bleed in deep-seated cavernomas. Hence, conservative management after the first symptomatic bleed and consideration for surgery only after the second bleed has been considered a reasonable alternative management strategy in the brainstem cavernomas. But believe me, in between these two options of surgery and conservative option, there is an option of radiosurgery. Because when surgery is too risky and the threat of hemorrhage looms, radiosurgery offers you a hope, a precise, minimally invasive answer for the most delicate real estate in the human brain, the brainstem, with an aim of prevention of the rebleed, because seizure is not a matter of concern here, and the deciding factors are the urgency and the severity of the bleed, the expected success rate and the expected risk and the complication safety profile with a particular treatment modality which you are taking for your patient and your patient is taking with you as a combined decision maker. So these are my indications for brainstem cavernous malformation radiosurgery once there is one or more clinically significant bleed. The MRI is typically suggestive of a cavernous malformation devoid of an true AVM, and I'm able to save the DVA. The surgical resection, the estimated risk is unacceptable to the patient. In presence of the multiple cavernous malformations, only the symptomatic one is to be treated. The early treatment of cavernous malformation with gamma knife was met with many problems, and the first cases were reported in Stockholm by Steiner and their associates in 1985. At that time, it was CT based, and they were using too much high dose, close to the tune of close to around 38, 35 gray, median, and 18 gray, and that was bound to create complications because the radiation tolerance of the brainstem is not more than 12 gray. And this opinion was repeated in the subsequent decade until the MRI and the concept in treating in the cavernous malformations changed. They stopped thinking that cavernous malformations are inactive lesions, because even if you go with the histopathological examinations, you will find that cavernous malformations, especially the familial ones and in the deep-seated ones, they continue exhibit endothelial proliferation and neoangiogenesis. So they are biologically active lesions. And these were the earlier skepticism. And even the own radiosurgical community was not aloof from this skepticism. If you go through this wonderful commentary published by Jishan P. Shihan in 2010, even in the radiosurgical community, there are two groups. One which give radiosurgery to the cavernous malformations, and the another one which do not believe in it or they do not usually practice it. While these same two groups keep giving radiosurgery to different other indications. Those who give, they think that we can reduce the rebleed rate by converting the bleeding vessel into the scar tissue by thromboembolism. But remember that these bleeds are not distributed evenly over the course of time. The another problem is that you will find that radiological signature of prior bleed on the scan continuously. As Dr. Lawton just told that an AVM gets completely obliterated and you get a histopathological evidence of this. There is histopathological evidence for cavernoma as well, and this was published in the autopsy series of those patients who were earlier irradiated or the patients who needed resection later on. This is by Carlson et al. In 1998. This was a brainstem cavernoma. By the end of 3 years, more than 75% of the cavernous malformation had been obliterated. So those earlier series had an unsatisfactory response because of their poor imaging. They were predominantly CT based. They had a poor targeting, including the whole of the hemosiderin as well. Sometimes they included the DVA, and the dose was close to the tune of 20 gray to 35 gray, and that was actually a Caesarogenic zone, and that can definitely create complications leading to the brainstem edema in those patients. There is no doubt that these brainstem cavernous malformations bleed more, and then you need to be more proactive with them rather than putting them on the conservative line. This is from one of my articles where you can see the red line. That red line is these brainstem cavernous malformation presenting with the ICH. In 2016, this was the risk of hemorrhage at 5 years according to the CCM location published in Lancet. And if you look at the chances of 5-year rebleed, the patients presenting with the ICH or focal neurological deficit with the brainstem cavernous malformation, the chances of bleed are as high as 35%, compared to the other brainstem cavernous malformations, which are just incidentally diagnosed. Even in those cases, the chances of 5-year bleed have been found to be close to around 15.9%. I would like to bring your attention to these two wonderful articles published in JNS in a single issue by Gabor Nagy and Matthias Redis from the Sheffield Group. And comparing a deep-seated cavernoma to the superficial cavernoma is like comparing apples with the oranges. They treated 210 patients of brainstem cavernous malformation with an early intention to treat even after the first symptomatic bleed. And they have shown that up to the 5.5 years follow-up, the annual bleed rate reduced from 2.4% per year to 1.1% after 2 years of gamma knife, and after multiple bleeds, it reduced from 2.8% to 1.3% per year. Pre-GKRS, the permanent deficits happened in close to around 41% patients with a single bleed and in 46% with the multiple bleeds. Post-SRS, they found interval bleed in 4.3% patients and the radiation-induced complications in 2% patients. This is a recently published meta-analysis we published in 2024 with a part of a multi-institutional trial for gamma knife radiosurgery. These are 14 studies from 576 patients. 96% patients did not had any increase in the cavernoma side. Either it reduced in 47% or remained stable in 49%. That's a surrogate marker of no rebleed. Because if a cavernoma bleeds, there has to be a new radiological evidence, either in the form of a new popped up intensity over there or the increase in the size, which we didn't find in these patients even after the 2 years. And close to around half of these patients were followed for more than 5 years. Symptomatic radiation-induced injury happened in 7%, while it remained permanent in only 2% patients. This is from Lunsford, only for the brainstem cavernous malformation. During the observation period, the 34% pre-SRS hemorrhage rate declined to 9.7% in the first 2-year latency period, which further reduced to 0.56% after the 2 years of SRS. So out of 446 patients, only 2 patients had a new bleed following gamma knife radiosurgery in these patients. They were criticized that the long-term data is missing, and this is a disease where you need the long-term data. The long-term data is not coming up. This is published in the Journal of Korean Medical Science. It's a Korean study. They published their 10-year-old data, the patients with the 10-year-old follow-up, and they could conclude that it showed favorable long-term results. It could be considered for cavernous malformation, especially in previous hemorrhage risk and the brainstem location, and I agree to their opinion over here. What happens once you treat them? There is one thalamic cavernoma, there is another brainstem cavernoma. These are my patients, and when I just follow them with a co-registered MRI, you can see the response which usually happens if you are careful in your patient selection and the targeting. This is 7-year follow-up of a brainstem cavernoma. That's a 3-year follow-up of a thalamic cavernoma. But you need to be sure, certain, and careful. Careful with your dose, not increasing it more than 13 gray, keeping yourself limited to the inner rim of the hemosiderin. Do not touch DVA because that may create complication. So people have tried some prospective trials. I say that it might have a chance of converting into another Aruba. This care group trial, which was published in Lancet 2024, and they compared the surgery, radiosurgery, and the medical management. And the primary clinical outcome, which included the deterioration or the rebleed, happened in 2 cases of surgery and 2 patients of the medical management, none in the radiosurgery, but the number is so less that it does not reach any statistical significance. And I call out for a large international trial, multi-centric trial. Otherwise, it has a chance to get converted into a RU. But one interesting finding in this study was that nearly twice as patients opted for radiosurgery in comparison to the surgical options. So it's a benign disease, yes, so far, compared to AVM and aneurysm. And if you can operate, we must operate over it to avoid rebleed. In hemispheric cavernomas, to avoid seizures as well. But if you operate, make sure you do not leave any residue over there. In the previous 2 talks, we talk about the residue. And this is a literature review from 1390 surgical cases. Complete resection could be achieved in 91%, and those 9% had a rebleed in 62% of the incomplete resected brainstem cavernous malformation. The surgery over them led to mortality in 1.5% and morbidity in 45%, with a long-term harm in 15%. So one question was asked by one of the attendees that if it is a first symptomatic bleed, should I just let it bleed once more? I find this action plan quite outrageous. We found symptomatic blood once. We thought that the surgical risk might be high. We know it's not near any surface, so it's a difficult surgical case. At this very option, we give an option of observation or surgery. But why not radiosurgery? How are we sure about the natural history when we know that there is a concept of temporal clustering of the bleed and there is a significant chance of the rebleed? And this rebleed is going to further worsen the neurological status of the patient. Many studies show that the people who have been operated say that they would like to get operated again if this happens to their brain after the second symptomatic bleed. Yes, we allowed them to deteriorate. We allowed them to have a debility, and then we thought that we were helpful and we helped them by giving a surgical option. And now if this complication happens, we say that the patient has earned the surgery, we are safe. This is the presumption of regularity. The return to work after brainstem cavernous malformation surgery is close to around 9 months. That's the time. And would you undergo surgery for the brainstem cavernous malformation? Yes, 90%. So if you are allowing them under the observation arm to rebleed, yes, probably that might be the answer. But I do not think that the patient should be allowed to suffer in that way. The first brainstem cavernous malformation was removed by Dandy. Since then, the surgical series are showing remarkable results. But we must listen to what Majid Sami told. Patients with the high preoperative KPS scores experienced a significantly better final outcome. That's why once you look at the surgical series, look at the outcome they are using, whether they are using a crude outcome like GOS or they are using something like an MRS or the Lawton scale, because this is definitely going to skew your interpretation of the results. And I think this Lawton brainstem cavernous malformation grading system is really a pragmatic one. And probably the patients who have grading 5 or more, they are the high risk, and you need to discuss the patient as a stakeholder in this decision making. So the outstanding question is not whether to treat inoperable cavernous malformation with radiosurgery or not, but whether to treat them earlier, that is after the first bleed. And in my humble opinion, waiting for the cumulative morbidity of the natural history to justify intervention does not serve the patient's interest. Now, coming to this article was also shown by Dr. Manas Panigrahi. The first article is a Delphi consensus on the surgical treatment. The second article is a radiosurgical guideline. So, whenever you are going through this article, be careful who are the authors, who are publishing them, and what are their personal inclination. In the first article, which is a Delphi consensus, these are the hardcore surgical articles. They did not give any consideration to the radiosurgery. Who publishes these results? The majority are ones who are the high volume centers, but the brainstem cavernous malformations are also being treated by other people, and the surgical morbidity and mortality by them is not being published. And these are wonderful. These are amazing surgeons who have done amazing job with a very huge experience. But are these all results so generalizable? That's one question which we need to answer. And in that way, I think the radiosurgical series have been more honest. The problem, whether with the surgery, natural history, or the radiosurgery series, are that most of these studies are retrospective, single center, short term follow up, lack randomization, diverse patient groups with a variable calculation of the rebleed. There is no definite follow up and the criteria of the evaluation of the rebleed. And that's why they were humble when I said that for patient with a surgically inaccessible or the eloquently situated brainstem cavernous malformation, SRS is recommended with the intent of reducing the risk of the subsequent bleed. This is Alliance for Cure guideline, and I was looking for any level 1 evidence for any treatment modality, and sadly, it was not available for any treatment modality. For radiosurgery, they consider radiosurgery as a
Sir,
key.
sorry to bother you. You have 5 more minutes.
Sure, I'll finish before that. So, radiosurgery may be considered for the solitary case brainstem cavernous malformation with the previous symptomatic bleed if it lies in the eloquent area. So, you'll need to look where is the bleeding pattern. If the bleeding pattern is like the last two slides, you need to definitely operate on them. But if it is first and the second, probably you need to consider radiosurgery, especially in the second one. What do I say to the patient? It will still show on the MRI? Yes, it will show. It will show till the end, until you remove it. So the benefit is clinical. Radiology is elusive in this case. But we would be able to know it worked if it provided you a clinical stability, seizure control. In the brainstem cavernous malformation, if it is just providing a clinical stability, that's good enough. And yes, you can create complication with any knife. Even in the radiosurgery, if you are going with the Linac based ones, the chances of complications are high because their dose fallout is less steep. That's why you irradiate unnecessary brain parenchyma, and that's why you need to be careful with your knife. We got better with the better targeting, keeping ourselves limited to the hemosiderin, and by doing the dose de-escalation. Critics and skeptics always doubt if the radiosurgery is taking the credit of the natural history of cavernoma in the brainstem, while the natural history carries a relentless risk of recurrent hemorrhage and neurological decline. Radiosurgery shifts the curve towards stability, transforming a progressive threat into a manageable condition. And if you follow your practices, then you wouldn't create a complication like a de novo cavernolar formation. If you are involving the DVA, you may land in a complication like I had landed 10 years earlier in this way. This was treated at my center, and the cavernoma disappeared, reduced significantly, but we had a rebleed because at that time the DVA was incorrectly taken up. We published this multi-centric trial. SRS is effective in reducing the repeat hemorrhage risk and yields a low rate of the permanent complications for patients with the hemorrhagic, surgically high-risk brainstem cavernous malformation. You can see the reduction in the rebleed rate within 2 years period. And if you look at the cost-effective analysis, even patients with the high-risk cavernous malformation, they can benefit from SRS rather than continuing the observation. So there is no question that the natural history of cavernomas overall is complex and only partially understood, and this applies to any therapy, whether it's an observation, surgery, or radiosurgery. Howsoever, we may remain skeptical to the value of radiosurgery for this indication. Reduction in the bleeding rate provided by gamma knife is a valuable therapeutic option. The strong opinions should be considered an opinion rather than the careful assessment of the scientific data. The Lawton grading system must be applied when chosen for radiosurgery for the surgical indication. It's a strong predictor, and we must remember the message conveyed by the SAMI and the BNI group regarding the choice of the selection of the patient. Patients with the high surgical risk are good conditions for radiosurgery, and in so many situations, The approach should not be just either or, but both and. Thank you, Pragyan, for this opportunity, and thank you, CBSI. Thank you so much.
Yeah, so wonderful talk. So it's open for debate. I'd like to ask the first question to both of you, Manas sir as well as you. So yes, the Cavernomas are detected once they bleed. Of course, it's true. But it is also true that unlike the AVM, which also bleed, and unlike AVM bleed, the Cavernoma with bleed is far, far lesser catastrophic. So when you say gamma knife is the treatment of choice for Cavernoma, there may be a clinical scenario in your clinical practice when a 70-year-old walks into your clinic with a bleed, with a Cavernoma which is blade fully functional without any deficit. And there is plenty of literature to say that it may never bleed again because the rebleed rates of Cavernoma also are far lesser compared to AVM. So why not observation is a treatment of choice in these cases? And number two, in if the cavernoma, of course, I understand if it's a deep-seated cavernoma, it is the surgery is cumbersome. There are more risks associated with surgery. But if it's in a safer zone of safer zone of cavernoma, which Dr. Lawton has nicely depicted, it's a superficial cavernoma. Why not take it out? I mean, it gives you instant relief. Instantly, you can say it's cured, unlike gamma knife, where you cannot say whether it's working or not because MRI is non-conclusive. So how that's the question. Why? How come it's a treatment of choice in these two scenarios?
Dr. Manas, should I answer or?
You answer the first part. Means
Okay.
this is an acute. Your presentation is a patient has come with an acute bleed, a 70-year-old man.
So 70-year-old who has bled, who has recovered, who has now come to the clinic, who is completely functional without any deficit.
In a brainstem, the Cavernomas in the brainstem.
Yeah, in a brainstem cavernoma.
So
Yeah.
that's the usual situation which happens. Now the
Yeah.
70-year-old with the first symptomatic bleed, he
But he will
recovered.
never bleed again, unlike AVM.
So that's one misconception once you are looking at a brainstem cavernous malformation, because around one third of them are going to bleed again. And this recurrent bleeding is going to cause a cumulative morbidity to those patients. This is a very tight zone, as we already discussed here so far. One third, or definitely the first point, is a misconception that they do not bleed. And that's why I have shown a couple of natural history studies was the chances of rebleed in the brainstem cavernomas are as high as 35%, especially in the patients who have a first symptomatic bleed, who presented with a focal neurological deficit or an ICH. So I negate this concept of that they are not going to bleed again. Their natural history that they wouldn't bleed is not as benign as we have been thinking, especially if it is in a thalamic or in a brainstem location. So yes, definitely I would like to offer them a treatment. Now, whether you should allow them to bleed again and then offer a treatment, or you should offer a treatment upfront now, I would definitely like to give an offer a treatment upfront at the first symptomatic bleed. And these radiosurgery studies have also shown that the chances of rebleed are significantly reduced. They have been reduced from 35% to less than 1%. Yes, it might take a little time. And even you are not sure in the natural history whether they are going to bleed within 2 years or they are going to bleed after 2 years. So, for how long are you going to keep this patient with you in the follow
How
up?
do you know whether the gamma knife is working? The MRI doesn't show that the cavernoma has vanished. It
It
shows
wouldn't.
that
It
it
wouldn't
doesn't
matter.
disappear.
At present, definitely, I do not have any MRI sequence which can show you that there have been a complete cessation of the capillary flow in that cavernoma.
So how do you
But
define? How
that's
do
a,
you define?
you need to rely on the surrogate marker once the cavernoma is static or it is reducing in size, because that's an indirect indicator that it is not bled again.
So
If it
why? How do
bleeds,
you define cure in GKRS in that case in cavernoma?
no, I cannot define a cure. There is no cure with GKRS. That's a palliative treatment option for a brainstem cavernous malformation.
Okay.
It's a palliative one. That's my disclaimer in the very beginning. It's a palliative. You cannot say that it's a curative one, because you do not make it disappear, unlike surgery. And regarding your second question, if it is in a surgically accessible zone in your health, yes, definitely go and operate on them. That provides you all these instant relief, chances of reduction of the rebleed and everything. Yes, definitely. But my point is for those ones which are surgically inaccessible ones or in the difficult zone. And that decision, apart from you, the patient has to be a stakeholder in that decision taking.
And what are
Yeah, but
yeah, yes, sir, please.
no, if it's an means, as you told, it's an now a patient is asymptomatic, but it's a superficial brainstem cavernoma, I assume what you're discussing, or a deep seated.
No, brainstem cavernoma, I mean, not
But if
exactly.
it's like if it's a superficial, if it's the first time, is asymptomatic now, means it depends on the individual surgeon. If he's confident to operate without creating deficit, that is what surgery is recommended. But if you look at the Delphi consensus, they tell that if it's asymptomatic, you observe them, do not operate. And but the deep seated, uh, as Manjul will, I think Manjul feels that both superficial and deep should go for gamma knife, or superficial. I feel superficial surgery and deep should go for gamma knife.
So sir, I told that same message that radiosurgery for the ones where it's a surgically it's considered to be a high risk one. Now comes the practical question. Once you offer the surgery, do you tell that there is a morbidity profile of close to around 15% in those patients despite using all of your armamentarium? So earlier you thought that an option is either observation or surgery, and the patients, as Dr. Lawton keeps 50% of those patients under the observation group. I just want to know how many of they land up into the surgical arm. What is the crossover of those patients? And probably that crossover of the patient, that particular percentage of those patients are the patients who could be benefited with the radiosurgery as well. Because
Yeah, but
radiosurgery, yes, definitely
life,
reduces the chance of rebleed.
but
So
in a
can I make a
70-year-old,
comment?
what will be the lifetime risk of rebleed according to Manjul? According to the literature, the rebleed what you presented, they are all young patients, but this is a 70-year-old man. What is the lifetime risk in this patient?
So let's first discuss the immediate risk, because once you look at the cavernoma, within 2 to 3 years, which is the time of the temporal clustering, there is a significant chance and close to around 30% of those patients, irrespective of the age group, slightly higher in the pediatric age group in comparison to the older elderly patients, there is close to around 30% chance that they would bleed within next 2 years. And then this risk would definitely reduce in the natural course, as we have seen in the various natural history studies. Compared to this, if you subject these patients to the radiosurgery, the chances of rebleed reduces to around 9%, and beyond 2 years, it further reduces to close to around 1%. So from 35% to 1%, this is a significant difference.
So can I
But
make a
this
comment here?
yeah,
Can
yeah.
I make a
But
comment?
before you make a comment, I just want to ask Manjul, this reduction from 30% 9% in the first 2 years of treatment. That's
Yeah,
what you mentioned.
yeah. And that's the literature answer in our own experience as well.
Okay, Dr. Tarak.
So I will probably agree with Manjul regarding the rebleed rates. Benign infratentorial cavernomas have a significantly higher rebleed rate than supratentorial cavernomas. Infratentorial bleed almost one third rebleed within the first 2 to 3 years. I mean there's no doubt on the data. While supratentorial around 8 to 10% rebleed rates are there, or probably lesser. Now the question is, would you treat on the first bleed? Absolutely. I mean, you should treat on the first bleed if the cavernoma is surfacing. I mean, there's no doubt about it. Now the only problem is if the cavernoma is surfacing, there is no doubt that surgery is the safest option, is the best option. The question is, what if it is deep seated and it is not a massive bleed, but it's a small bleed? Would you like to treat the patient or not? Is the question. That I mean, gamma knife data, generally historic data, has been skewed by the fact that the uh, dosage used were traditionally very high. And when you use such high dosage like they used to use before, there are bound to be complications, and there are going to be what you call the hemosiderin acting as a radiosensitizer. The inherent dose itself being high, because if you see the tolerance of the brainstem, it is not more than 12 grays. So if you're going to give 18 to 20 grays to the brainstem, you're definitely going to have damage to the brainstem. But I mean, we have learned our lessons. But having said that, uh, whether we would give radiosurgery for deep-seated cavernomas is controversial, simply because of the fact that radiosurgery itself has lots of side effects, which which are significant. It ranges from 5 to 15% in literature, even with the low dosage. So This has to be discussed with the patient regarding the surgical risk, regarding the rebleed risks, and the radiosurgery risk. I mean, it's not an easy decision to take as to what I would recommend. I mean, you should make an informed choice to the patient, saying that if your rebleed rate is going to be high within the first 2 years and then it is going to come down, versus around 10 to 15% complications for gamma knife, I think that is something which you should tell it to the patient and let him make it call. There is no hard and fast rule at all.
But I would like to contradict here with your data of the radiation induced complication in these patients. You need to divide the literature before 2010 and the literature after 2010. And after 2010, the radiation induced complication, the symptomatic one, have reduced to 2%.
Absolutely, I agree.
So
But Manju,
15%,
yeah,
15% to 2%, that's a very, very significant difference. And then once you are treating with the radiosurgery, you need to tell which particular machine and which particular dose you are doing. If you are using it with the machines which have a lesser sharp dose fall off, you are definitely irradiating the brainstem. And then you are bound to create complication in that tight zone.
I think that's also a very important point. The dose fall off. I mean, if you go see the dose fall off for a LINAC based system versus a gamma knife system, there's definitely much more side effects with the LINAC based system than a gamma knife system. I mean, that there's no doubt. But you see, radiation is a double-edged tool. Use it wisely, it is good. But if there is even the slightest mistake, you're bound to create complications, especially in areas of brainstem. I mean, there's no hard and fast rule. That is finally my
So,
conclusion. I mean, we have done almost some long history of 17, 18 years so with gamma knife. But we have treated very few gamma brainstem carcinomas. I mean, that is a
so
fact.
also,
Can
sir,
I ask a question to both of you? Ask both of you. Why does the rebleed rate comes down after 2 years in AVM, and then you tell in Cavernoma the rebleed rate it reduces significantly in the first 2 years, whereas in AVM we think of the reduction of rebleed rate after 2 or 3 years.
So that's probably because of the pathological response of Cavernoma to radiosurgery. The current concept that it does not show any pathological reduction is wrong. If you go with particular literature which have published the resected cavernomas after radiosurgery, they show obliteration of that blood flow in those caverns. It happens. As I told in the Carlson study, this was published in 1998, which was way earlier, and those subsequent studies have actually shown it. Yes, you keep seeing a hemosiderin ring, that you would keep seeing the hemosiderin ring until you remove it, but that is because of the old bleed, not because of the new one. So the timeline, as in currently in the AVM, you think that within 3 years it would be a complete obliteration because there was a nidus which was visible earlier is not visible. We are happy that we have cured the AVM. In case of a cavernoma, we cannot say that at present radiologically, but yes, if you go with a pathological specimen of that one, there is an obliteration of those caverns because of the endothelial proliferation or something, and that is on a variable timeline, probably dependent on the dose, probably dependent on the size, and probably whether it's a lesional bleed or extra lesional bleed. So that literature has to come up. Right now I say that the evidence is more clinical rather than radiological in these cases.
I mean, that's a very important point on cavernomas that unlike AVMs, they do not disappear. It's only the rebleed rate which comes down. And the other point which we forgot to mention, of course, was previously they use the entire cavernoma, including the ring, as the target. But right now we are excluding the ring and targeting. So it's only the cavernoma, not the ring. So all these things have made it safer.
so sir, I'd like to ask
But
one
there is
more.
there, but just Pragyan, just to let me finish. There is definitely more and more data coming out on the efficacy of gamma knife in cavernomas, and I think if it's a deep-seated bled once, rather than waiting it for to rebleed, it could be a feasible option.
Again, there are some questions in the
Yeah, so sir,
chat
before that,
box.
I'd like to ask you something that, yeah, we'll take those questions. I think that there are questions put by Dr. Manish Benual. We'll take those questions. So
Dr. Hemant also in the chat box, in the QA box.
yes, there are. So I just like to ask one question from my side. Of course, bleeding is a risk if more so in subtotal resection. And if you supposing operating a brainstem cavernoma, the most common region of subtotal resection is bleeding during the surgery because you cannot coagulate or it's not possible to coagulate there. So supposing it is bleeding, exactly at what stage you decide that you are going to go for subtotal resection and you are not attempting total resection. And
Okay.
in such a case, if there is a residue and it bleeds again, will you operate or GKRS? And reverse also, supposing you are giving a GKRS as a primary treatment, during the follow-up period it has bled, will you do GKRS again or will you operate?
Pragyan, first thing is the thing is that the subtotal resection is because of bleeding is completely not correct.
Not correct.
The main reason for subtotal resection is inadequate visualization, and that is because of selecting the wrong approach.
Okay.
Okay, so there is no way. I mean, we have done. I've done quite a few of brainstem cameras, more than 50 of them. The there is no inadequate resection if you can visualize it properly, because the only fallacy is that if you do not take a proper approach, what happens is the cavernoma gets flattened out and you tend to miss the cavernomas.
So suppose it bleeds, then what is the
Cavernomas
strategy?
don't bleed much. Cavernomas bleed नहीं करते. अगर bleed होता है तो that means you have entered the DVA.
No, sir, follow-up
Venous
period.
bleed.
Supposing there is a subtotal resection, follow-up it bleeds. So will you
Ah,
operate
then you
again
have to
or
go
care?
back and reoperate. You have to go back and reoperate.
And supposing GKRS you have given and it has rebled during follow-up, then
GKRS is not an immediate option. GKRS, it takes 2-3 years for it to start acting. We're talking about immediate prevention of bleed.
okay, so I think we can take those questions in the chat box. There are a couple of questions by Dr. Benival, I think. So he is asking to Dr. Manjul, what is the time period after surgery if you are planning ZKRS in case a residue is seen in post-op MRI? And do you think the complication rates is high in some centers because they use CyberKnife? It's in the chat box.
Sure, these are actually wonderful questions. The first question is a very practical one. What is the time period? First, you do not need to jump on that cavernoma if you see a residue. If you have operated, definitely there might be some post-surgical artifacts if you have put some Surgicel or just a hemosiderin ring is there. So first make sure whether there is a residue there or not, and all your surgical artifacts have disappeared from the post-op radiology. If you think that this is a surgical artifact and you are not sure in the definition of your cavernoma, wait for again 3 or 4 months so that the surgical artifacts disappear and then you decide over it. Supposedly again you see a cavernoma over there. I would definitely like to give radiosurgery to that patient. We have already tried surgery once. There must have been some difficulty either because of the plane, because of the bleeding, because of the DVA, you couldn't remove it. Now going again for a redo surgery is a difficult task in that patient, and the patient's acceptance is also going to be less. So for a practical standpoint, I would definitely recommend radiosurgery to those patients, but I would wait for a sufficient duration of time to be certain about it. Regarding the second question, do you think that the complication rates is high in some centers? Without taking the name of any particular treatment modality, I think once you are dealing with these eloquent structures where your radiation tolerance is pretty low, you need to actually go with the treatment options which can provide you the steepest dose fall off. And that is best possible with gamma knife. So if you go with that, you are definitely going to avoid irradiating surrounding brain parenchyma. Brain parenchyma's radiation tolerance is pretty less. And one thing that might be a slightly from the radiosurgical perspective, in the spinal cord and in the brain stem, the circuits run parallel to each other. So their radiosurgical tolerance to a particular dose is entirely different from the radiosurgical tolerance of a cerebellum or cerebrum. That's why you need to be very limited in your dose and in your targeting. That you can achieve with gamma knife at present. And that's why the results are much better in the gamma knife series in comparison to the other series. I hope I answered this.
Yeah, I think Manas sir can answer the final question and then we can conclude. If anybody has experience of operating on a post-ZKRS case, do you find it more difficult?
No, I have
I
not.
have. I have
You
operated.
I have not done. Huh?
No, I have operated on a couple of them, and it's not difficult. Since we keep ourselves limited to the hemosiderin, there is no fibrosis, no loss of plane, and it's as easy as to operate on a virgin cavernoma.
But Manzul, I have a question to this. Means after how many days of gamma knife there was a rebleed? Why did you operate?
So because it rebled. It rebled and it rebled within 3 months. And it was a significant bleed, so I had to operate on that patient. But Means I didn't find it difficult from other brainstem cavernomas which we operate.
Okay.
Means after how many cases you had rebleed? How many? What percentage of patients had rebleed?
Sir, only if you look at the brainstem cavernous malformations, what I remember means I have done close to around 98 patients and I have a good follow-up of around 10 years now. So in those cases, around 3 patients had a rebleed. And in 2 patients, I had to operate because they were symptomatic and large enough bleed to be operated. But rest were asymptomatic one.
All of them were within 3 months, or it was different time periods?
No, sir. One bled after 2 years.
Okay.
Okay, so again, on behalf of Cerebral Muscular Society of India, I sincerely thank all the speakers and the panelists for your valuable time and taking time from your busy schedule to be present for this webinar. Sincere thanks, sincere gratitudes. It was quite a successful webinar. I think the attendance at the peak crossed at 1.90. So the next webinar, I think, is scheduled for September 3rd, Thursday. The topic will be, the international guest faculty will be Maxim Sapiro from Buffalo, and we'll be discussing another emerging entity, the endovascular venous stenting in cases of pulsatile tinnitus and venous stenosis. So from CVSI, and again, after offering sincere thanks to Icon Pharmaceuticals for all the logistics that they have provided, I conclude this webinar. Thank you very much and good night.
Good night.
Thank you. Thank you, everyone.